So thank you very much for the kind invitation to share with you today an update on bacterial testing in platelets. I would like to start with some objectives. First of all, we will describe the screening process that we have followed at Canadian Blood Services to test platelet components for bacterial contamination, and I will end up sharing some updates on testing results. As we know, Canadian Blood Services manufactures 3 blood components: red blood cell concentrates, plasma, and platelets. And platelets are stored in gas-permeable plastic containers, and they need to be active to be stored at 20 to 24 degrees under agitation. And these conditions are also amenable for the proliferation of any contaminant bacteria. So what are the mitigation strategies that we have implemented at Canadian Blood Services to reduce the risk of transfusing contaminated platelets? We have the first aliquot diversion. We also have implemented skin disinfection methods and more recently pathogen reduction. However, I would like to focus today on bacterial testing. So what is the method that we use for bacterial testing? Is the Bacterial 3D system, and it's basically a shaking incubator. We take samples from platelet components and inoculate BPA, aerobic, and BPN, anaerobic culture bottles. And if microorganisms grow there, they will produce CO2 that in contact with water will reduce the pH. And the change in pH is sensed at the bottom of the bottles, and the system will alarm saying that is potentially bacterial growth in these culture bottles. So we store platelet concentrates for 5 days until August 2017, and then we extended the shelf life to 7 days using a large volume delay sampling algorithm. And this algorithm involves, first of all, to sample platelet components at least 36 hours post-blood collection, in contrast to the 24 hours that we had before. We have also increased the volume by inoculating 2 culture bottles, aerobic and anaerobic, and before we were only using the aerobic culture bottle. For double apheresis units, we inoculate 4 culture bottles. And the last change is now we are quarantining the units at least 6 hours post-sampling to allow for any fast-growing bacteria to be detected. And after this, the units will be released into inventory with a negative to-date result. So we have some challenges to detect contamination in platelet units. And the first one is due to the growth dynamics of bacteria in platelet concentrates. We have 3 scenarios here: a fast-growing bacterium, then another one that grows a little bit slower, and one that is really considered a slow grower. So what will happen if we take a sample at 36 hours and inoculate a culture bottle? We have 3 scenarios. We can actually detect bacteria because it was grew to a concentration that allowed for detection, or we can have a very low concentration, and based on the distribution of the bacteria in the component, we may capture or miss the detection, or if it's a very slow grower, we may miss the contamination here. And the second fact that we should consider also is the growth dynamics in the culture bottle. So we may have bacteria in the bottles, but some of the organisms will grow really fast, and after 1 day, we may say, okay, we have a positive result, and we were able to record the unit before it gets transfused. In other cases, organisms grow very slowly, and then in these cases, the unit will have been released into inventory, and we don't capture that before being transfused. We have a very complex testing algorithm or the categorization of the results. However, for simplicity, I have this diagram here showing that if we have an initial Bacterial positive result and we do some testing and no bacteria are isolated from those culture bottles, and during confirmatory testing with new culture bottles, the results are negative in the Bacterial system, we call this a false positive. On the other hand, if we isolate organisms from the initial positive culture bottle and from the confirmatory culture bottles, and the identity is the same, This is what is called a confirmed positive result. So what are the merits of this system that we implemented almost 20 years ago? And as you know, now we're in transition of changing. First of all, I want to show the results of platelet screening, and it's updated until September of this year. We have 5 days platelets here and 7-day platelets, Buffy code pools, and single apheresis units. And the first result that I would like to share with you is the fact that we have increased the detection of contaminated units by approximately 11-fold. You can see that here for Buffy codes and 4 times for apheresis units. However, most of those organisms are captured in the anaerobic culture bottle. And if we want to compare apples and apples, before we were only using the aerobic culture bottle, and we were only detecting aerobes and facultative organisms, we have basically doubled the detection for Buffy code pools, but the rate for apheresis units has remained the same. Now, with any system, these are the benefits, but also we have a pitfall, and is the increase of the incidence of false positive results, also with the anaerobic culture bottle for approximately 5-fold. Importantly, we have been able to capture units that were contaminated with what we consider pathogenic bacteria. It does not mean that there are no transfusion reactions with the skin contaminants, but we know that if a unit has gram-negative bacterium, the possibility of having a septic transfusion reaction is higher. So we have interdicted those units, and this is the major benefit, basically the safety of the patients. And another benefit that we observed when we extended the platelet shelf life from 5 to 7 days in 2017 was a decreased rate in outdates of platelets, both at Canadian Blood Services and at the hospital. And with data until December 2019, the decreased rate was approximately 5%, and we saw this transferring in saving money. And after that, I think this low rate of discard has been maintained, and probably there will be more with the implementation of Intercept. So what are the other benefits that I think sometimes we forget and for me are important when we culture platelets? One of them is that we follow up donors that have pathogenic bacteria. They have silent bacteremia. They may be unaware of certain issues. As an example, there have been reports in the literature, if a donor has Streptococcus bovis, they may have colonic cancer. That's an example. The other benefit that I can see when we test pools, for example, is that it's a surrogate test for other components like red blood cells and plasma units. And as I mentioned before, we also have some pitfalls. And basically, for me, what is more important is to discuss the residual safety risk. And I will start with the transfusion of units that have delayed bacterial results. For this, I want to focus your attention on Cutibacterium agnes. It's the predominant organism isolated from both Buffy code pools and apheresis units. And we know that it's part of the normal skin flora. It's considered that it's non-pathogenic, and we usually dismiss the fact that we are transfusing a large number of platelet components that are contaminated with this bacterium. And the reason that we actually transfuse these units is because this bacterium is a very slow grower. It can take up to 7 days to get a positive bacterial result. But we don't get the typical report of a septic transfusion reaction with units that have been transfused that are contaminated with this bacterium. However, I have always thought something that we shouldn't forget. What will happen with that patient that received that contaminated unit with this bacterium in the long term? We know that C. agnes has clinical implications because it produces biofilms and it increases inflammation. It has been associated with different diseases. And then I think that we are missing that part of the puzzle with bacteria that are not causing the typical transfusion reaction. The other scenario that we have is that the bacterial system doesn't detect bacteria. And in this case, it's what we call, a false negative result, and it can be captured by 3 different scenarios. The first one is if we have a transfusion reaction, we investigate, And we found that the unit was indeed contaminated, even that the initial culture yielded negative results. That's what we call a false negative. But it was indeed contaminated. We know that bacteria will continue growing during platelet storage. In the other hand, we also have to do a screening of outdated products as part of our quality control program. And in some cases, we can detect contaminated units that yielded negative results during initial screening. And also, we have the near misses that are captured by visual inspection. Sharing some data up to September 23 about our quality control of expired products, you can see that for Buffy codes, it's like a 1 in 1,200, and for apheresis units, almost 1 in 3,000. Units that yielded negative results during the original screening, and then they were found to be contaminated. So we are missing quite a few of these units that are contaminated during initial screening. When we extended the platelet shelf life from 5 to 7 days, we decreased the rate of transfusion reactions, and that was the purpose, to increase the safety of this component. However, we have 2 confirmed reports of units that were contaminated with Staphylococcus epidermidis, and another one with the Staphylococcus aureus. And this one, we actually published the case because we found that this specific strain of Staphylococcus aureus produces exotoxins, and the toxin was found in the platelet component. And more recently, in February of this year, we have a near miss, again with the Staphylococcus aureus. The unit tested negative with the Bacterial system, passed all the inspections until it was just almost ready to be transfused, similar to the case that Christine mentioned this morning, but this one was captured before the transfusion started, and this highlights the importance of visual inspection. So we know that the implementation of bacterial culture of platelet components almost 20 years ago was a reactive approach, and it was what was available at the moment. This review that we published with Hani Kamel as the first author last year nicely summarizes the fact that we have pros and cons of when we implemented this mitigation strategy. Of course, we have captured units that are contaminated, but we missed others due to the fact that some bacteria grow very slowly or that they form biofilms. And more recently, in January 2022, as we heard this morning as well, we implemented a proactive approach. And it's great. Now we have pathogen-reduced platelet components. There's a lot of data in Europe showing that the safety of these platelet components has increased. However, the question is it foolproof? It's perfect? It is not. You have here a recent report from the CDC that summarizes a few cases. I think it's 7 or 8 cases that happened since 2019, including some platelet units that were treated with Intercept, and they were found to be contaminated, transfused. Some of them caused fatalities. There is some discussion that, at least in some cases, it's possible that the unit was contaminated after treatment with Intercept. Nothing has been completely confirmed, but it's important to know that there are some breakthroughs. And for me, the most relevant one was the one that was presented from France this year at the ISBT Congress, when they showed that there have been captured 3 units of platelets that were treated with Intercept, and they were contaminated with bacteria. One was transfused, caused a transfusion reaction, and it was contaminated with Bacillus. We know that the sporulated bacteria will resist the treatment with Intercept. But what was surprising for me is that one of the 3 units had Staphylococcus aureus, and another one has Staphylococcus epidermidis. And that's surprising because those bacteria should be inactivated. So with that, I would like to acknowledge the people in my lab and other colleagues who provided data that I shared with you today. This is a team effort, and I really appreciate their input on this presentation. And I want to thank you for your attention, and I will be happy to answer any questions that you may have.